open. I've been open since February, and we'll go ahead and start the presentation. So, women's hormones. One of the most important things about women's hormones is it's going to be unique to each person, just as your fingerprints are unique. Not everyone is going to respond to hormones the same, and hormone replacement should only be considered when you understand how the body's hormones interact with each other. That's both for the patient that is on hormone replacement, as well as the medical provider that's using hormones. The normal age to go through menopause is going to range from 35 to 55 years old. And some women can actually be perimenopausal for 10 years before actually hitting menopause. And so essentially what that means is you can start having fluctuations in your hormones where you're starting to have symptoms of menopause, but you're not quite there. Estrogen is stored in fat cells, and so thinner women are going to lose their estrogen much sooner. Heavier women will hold on to their estrogen, and so just because they're going through menopause and estrogen is coming down, they may not experience hot flashes from that significant decrease in estrogen levels as you go through menopause, and that's the reason why. Some symptoms of menopause, of course, what I hear most commonly in the clinic is the hot flashes and night sweats, vaginal dryness, anxiety, mood swings, anything to do with mood. And that's because all of your hormones play a role in how you feel. Estrogen has over 400 important functions in your body. And a sign of aging, or when you start aging significantly quickly, it's due to the loss of estrogen in your body. Aside from the mood, you can still get migraines, especially if you had migraines when menses started. They may get worse or they may actually go away. Another big complaint that I hear is memory lapses. So forgetting where you left your keys, or forgetting what you want to say or what you're talking about in a conversation. That is very common because our brain utilizes estrogen, and it's very important for the brain to have estrogen. Weight gain is another symptom, and we'll go more into that. Gut issues or indigestion, and that's because all of our hormones are going through our gut. And then hair loss is another symptom that is very common with hormone replacement or the lack of hormones. So how do hormones work in the body? When I talk about sex hormones, we're going to be talking about DHEA, progesterone, testosterone, estrogen, and then sex hormone binding globulin. I won't be going into sex hormone binding globulin in this presentation, but I do just want to put it out there that it actually acts as a protective mechanism. And so hormones are broken down by DHEA into progesterone, into testosterone. And even if your body is making testosterone, when the body is under stress, sex hormone binding globulin is going to hold on to testosterone, or if there's too much insulin in the body, or chronic infections. And so even if you're making testosterone, your body may not be getting it. And you have to produce testosterone before you start making estrogen. And there are 3 different forms of estrogen. E1, or estrone, and that is the form of estrogen that actually increases your risk of getting breast cancer, cervical cancer, testicular cancer in men, or prostate cancer. E2, or estradiol, that is the good estrogen. It's what makes us feel like women. It's the estrogen that we want our body to have, and it's actually protective for all of those different body functions that I previously mentioned. E3, or estradiol, it's significantly high during a pregnancy, and it's actually just eliminated in sweat and urine. There are some functions of E3 in the body, but we're going to focus mainly on E2 and how to prevent E1 from building up in our system. So first we have to know how hormones work, and that's the hypothalamic pituitary ovarian axis. The hypothalamus is going to tell the pituitary to start secreting gonadotropin hormone. That's your growth hormone. And as you age, that also starts to decline. And so you've probably heard of diets that talk about replacing growth hormone, and it's for this reason here. It stimulates or tells your ovaries to start producing FSH, which then contributes to the production of estrogen in the body. When you go through menopause, it's just it's a dysfunction between the HPO axis, but more importantly is the hypothalamus, pituitary, and adrenal axis. I don't go too much into talking about the adrenals in this presentation. That was a separate presentation that I did last week, but I do want to mention that, how important the adrenal glands are to the hormones in the body. Your adrenal glands secrete cortisol, and there are two forms. You have cortisol and cortisone. The adrenal glands sit on top of the kidneys, and when the adrenal glands are under stress, that's what puts your body in fight or flight. So instead of making cortisol, your body starts to make cortisone. Cortisone can't be utilized by the brain. And so that's when you start to experience brain fog, forgetfulness. And so what it does is, under stress, it just sits around the abdomen, because that's where your adrenals are, where it's secreted. There are three hormones that cause weight gain in women. That's going to be estrogen, cortisol, and insulin. All of these are affected by menopause. One of the big takeaways when talking about the adrenal glands is cortisol is actually the key that lets the hormone inside the cell. So if you look at the second picture here, a hormone is secreted from one cell, and then it travels through the blood, and it knows exactly where it wants to go and what it wants to do. When it finds its target cell, then it's going to attach to receptors on the target cell. Those receptors, when you're talking about hormones, actually need to have magnesium and zinc on it in order for that hormone to cross that cell membrane. And you also need healthy levels of cortisol, because cortisol is the key that lets the hormone in the cell. So when the body is under stress, or if you have burnout or chronic fatigue, and you're not producing healthy amounts of cortisol, then you're going to experience symptoms of menopause or low or deficient hormones in your body. So it might not actually be related to menopause or perimenopause. It could be related to the adrenal glands. And so when I'm taking care of patients, I always want to know what their adrenal glands are doing for that reason. And that's why I mention it in this presentation. Before talking about hormones, I have to talk about COMT. COMT is actually a gene mutation. You can carry one or two traits of this. It is estimated that 20 to 30% of people in our population have a COMT gene mutation. And it's an enzyme that helps your body break down dopamine, serotonin. It primarily affects the central nervous system. And so I personally have a COMT gene mutation, and I'll just share a quick story. When my anxiety level is really high and I'm looking at life circumstances, I have nothing to be anxious over, but I can easily feel like I'm waiting for something to happen. If you've ever had that feeling, then you know that it's not the best feeling or it's horrible. And so it primarily affects the central nervous system, and it's because of that COMT gene mutation that the mood is affected. And I talk about the COMT gene mutation because it's important to getting estrogen out of your body. With that in mind, this is the methylation cycle. Some people have an MTHFR gene mutation, about 30 to 40% of the population, and you can carry 1 or 2 gene mutations. And what that means is you're not getting B vitamins inside the cell, which is essential for many important chemical reactions in the body. You have to get B vitamins in order to metabolize your hormones. And if you can see at the very top of the chart is COMT. So not only do you have to methylate your vitamins, but you have to be able to metabolize hormones, and there's another gene mutation that can affect that process. I have talked with some patients about vitamin B6, and B6 comes from methylation and metabolism. And if you're not doing these two things, then you're not making B6. And if you've ever heard of neuropathy, that's numbness and tingling in your feet and legs, it's very common in diabetics. However, when it's not related to diabetes, it's called idiopathic neuropathy. And a lot of patients have idiopathic neuropathy, and it's from a vitamin B6 deficiency. Now, when you mention this to a provider, they're going to look at what B6 is doing inside your blood, and they'll say, oh, your B6 looks great, which isn't always true, because when I look at patients, I'm looking at what B is doing inside the cell. And so this homocysteine value is one of the things I look at. And when homocysteine is really high, that's because you're not methylating or metabolizing appropriately. And to treat those patients, I use methylated vitamins. We don't use methylated vitamins in everyone because it can actually speed up cancer in patients who don't need it or have this gene deficiency. And so looking at labs is going to be important. Now, when you consider that only 30 to 40% of the population is affected, it's easier to just tell people to take B vitamins. And we know that folic acid is so important to maintain a pregnancy. We tell pregnant moms to take it to maintain that pregnancy, but some women will have miscarriages, and that's because they're not getting folic acid inside the cell. And so in those patients, you want to look at what vitamin B is doing in the body. And I mention it because it affects your hormones, it affects your mood, and it affects multiple chemical reactions in the body. Where it talks about glutathione synthesis, glutathione is essential to getting toxins out of the body so that you don't have too many free radicals that can lead to cancer as well. And so those are some things that I look at in my patients when I'm considering hormone replacement, and not all providers look at that. I have this steroid pathway. So this is by Dutch test or precision analytical because it's looking at the hormones. When you look at the very top of the chart, you can see cholesterol, and it has a direct correlation with DHEA. And that's because all of our sex hormones are steroid driven. You have to have cholesterol to make your hormones. But sometimes you have too much cholesterol, and that can actually hurt you and not help you. And so we'll be looking at the studies on cholesterol and how hormones affect heart disease. But it's important to know what someone's cholesterol is doing in their body before you start or consider using hormones in patients as well. But DHEA breaks down into progesterone, as I had previously mentioned. And then there are some providers who will use very high doses of progesterone in patients. And progesterone, if you look at this chart, actually can turn into cortisol. So The patient might feel really well initially on high doses of progesterone, but then they start gaining weight, and that's the weight that sits around the kidneys, and it's because of this inactive form or cortisone. And so there has to be a balance in hormones. Progesterone breaks down into testosterone, and I occasionally see women on very high doses of testosterone. It's not safe, or taking DHEA over the counter is not safe, because as you can see, here's your estrone or E1, estradiol or E2, and estriol or E3. Remember, we want to have E2 in our body. This is what makes us feel like women. When you have too much of this E1, that's because those high doses of DHEA and testosterone are going down an incorrect pathway. And you can see here on the bottom where it says COMT, if you have this gene mutation, which 30 to 40% of us do, then you're just increasing that person's risk of getting breast cancer. So what are the sex hormones? Let's talk about them individually. DHEA, it's secreted from the adrenal glands, just like your cortisol. And so I personally don't like to use DHEA in women. I often find that it makes them feel literally crazy. And it causes weight gain. In patients who have a hard time resetting their adrenal glands, I will use DHEA. So again, hormones are not the same for everyone, and some patients will do good on it and some patients won't. DHEA is important because it affects stress, and that's because they both come from the adrenals where cortisol is released, and the adrenals are highly affected by stress. It decreases cholesterol in the body, prevents blood clotting, increases bone growth. And what you're going to find as we talk about the hormones, they often cross over. And so it can look like a DHEA deficiency, or it can look like a testosterone deficiency. And so having a provider that understands hormones is going to be important, because you want to make sure that you're getting balance appropriately. DHEA starts to decrease the beginning of the fourth decade in life. And as you get older, DHEA levels start to come down. So if you've ever looked at labs for DHEA, women tend to feel better when it's around 200, but that's when you're in your 20s. You also don't want to replace DHEA because it can contribute to high cholesterol, because there's a direct correlation or relationship between the two. And so putting everyone on DHEA isn't smart for that reason. DHEA also has an influence on your immune system. And so as you age, if you've noticed that you tend to get sick easier, it's from a lower amount of DHEA in your body. It decreases your allergic reaction to food or to your environment. And also, as you get older, we tend to see more food sensitivities. And so hormones are going to be important for that reason as well. Progesterone. Progesterone downstream from DHEA actually affects our mood, and it affects our body. So both muscle and energy and skin. When you're perimenopausal, you might have had excessive menstruation and been put on progesterone, and that's for this reason. Progesterone actually protects the uterus, and so it's good in patients that don't get enough progesterone, whether it's during menses, perimenopause, and especially after menopause. More importantly, that's what you need in order to get good sleep. And we'll talk about how progesterone and estrogen affect sleep a little later on. Testosterone. There's this common misconception that if my testosterone is really high, then my sex drive is going to be really high. Testosterone is going to affect your libido, and so that's arousal or lubrication or orgasmic power. It's going to improve your sex drive. But you actually need estrogen in your body because estrogen is what creates the desire. You don't get that from testosterone. And so if there's no desire, you could just have a really high libido and be really upset. Frustrated, yeah. Testosterone increases stamina. We know that that's a fact. It affects lean body mass. It also affects your brain and how you're able to process information. And so having healthy levels of testosterone is very important, but I tend to get patients that come from other providers who will treat someone's testosterone. So for example, testosterone should be 50 or less. And I'll get some patients where their testosterone is 150 or even 300. And the person replacing their hormones is okay with that. There are two reasons why that's not good. One, which is most important, is testosterone causes vasoconstriction in your body. And so those women, and I have heard of these patients who have actually had a mini stroke, a stroke, or a heart attack because of high levels of testosterone. When you look at a man's hormones, their testosterone can range from hopefully not 100, but around 100, all the way up to 800. And if you remember, women's is less than 50. And so men are at higher risk of having a stroke than women until women reach menopause. And the reason that is because estrogen comes down, testosterone can be higher, but it affects what's going on with our blood vessels. And a woman's risk of having a heart attack or stroke is going to be 10 times higher a man's risk post-menopause. And for that reason, you don't ever want to lose estrogen in your body. And we'll talk about estrogen and why that is. So estrogen prevents Alzheimer's disease. And so Alzheimer's disease is actually higher in women than men. And that's because we need estrogen in our brain. It decreases LDL, which is the bad cholesterol, and it increases HDL, which is the good cholesterol. It helps maintain elasticity in arteries, inhibits platelet stickiness, and platelets are what aggregate when the body has inflammation. And it's good when you're fighting inflammation, like when you get an immediate injury to your arm or something, it helps blood clot, but you don't want that to happen unless it's acute. And that's because without estrogen, you get more plaque formation on the arteries. When you look at estrogen in women, as estrogen comes down, and I always say this to my patients, but more for with myself, when I go through menopause, I will not let more than 5 years pass by without being on hormone replacement, because as estrogen comes down, the veins and arteries start to stiffen, and that's the loss of elasticity. As those veins and arteries stiffen, that's why your risk for having a heart attack or stroke goes up. Not only are they stiffening, but now you're getting platelet formation that's causing plaque in those arteries and veins. When you use estrogen replacement in a postmenopausal woman, you have to know what's going on with their cholesterol in their arteries and veins. So again, hormones are unique, like fingerprints. Not everyone is going to be the same. Risk factors are not going to be the same, especially if you're looking at somebody who is a smoker or has been a smoker. That also contributes to loss of elasticity. Once you introduce that estrogen, it's going to soften or cause elasticity in the arteries and veins again. When that occurs, and there's a platelet or a blood an accumulation of plaque on that artery, that plaque can get dislodged, and that's what causes a blood clot. And so you have to be careful when you're using hormones in menopausal or postmenopausal women. Estrogen is important for sleep. And I had mentioned progesterone helps you sleep. You have to have both progesterone and estrogen within the hippocampus of the brain. As you go through menopause and these hormones start to decline and you're not able to fall asleep as easy as you were when you were in your 20s or 30s, that's because you don't have enough estrogen and progesterone in the hippocampus. Now, that is what makes you feel tired so that you want to go to sleep. But if you're one of those people who wakes up multiple times during the night, that's because not only do you not have enough estrogen, progesterone in the hippocampus, but it's not getting placed in the amygdala. And that's where restful sleep comes from. And so you never want to lose hormones in your brain. I like this slide. I don't think you understand how these hormones work. It's frustrating for patients, and that's why it's important to go see someone who does. When you're looking at hormones, so many people are not on hormone replacement, and that's because the information isn't out there, or there's a misconception of what hormones actually do in the body. And so we'll talk about a couple of those things right now. The hormone replacement therapy study, this was during the Women's Health Initiative. In 2002, there was over 1,800 women who were part of this study, and it's one of the very few that they actually had to stop. The reason why they had to stop the study was because too many women were dying of a heart attack or stroke. And then they learned that it can actually increase the risk for breast cancer, heart disease, strokes, and blood clots in women. The true science behind this study is when they were looking for the 1,800 women to participate in this study, they were looking at women who were already on hormone replacement. And when you ask a woman to stop her hormones and consider being put in a placebo or a treated group, no woman wanted to volunteer for that. A lot of the patients fell in the 60 to 79 or 50 to 69 age groups. So they were already postmenopausal. A lot of the women were smokers. And so you have to look at the participants in this study and where the research came from. And that's what I want to talk about the most today. So these were postmenopausal women. They haven't had any estrogen for many years, and they were using Premarin or Prempro. Premarin and Prempro are synthetic hormones. What that means is it comes from pregnant horse urine. And so when you pull estrogen from pregnant horse urine and you put it in a human, it causes vasoconstriction. And so these women already had vasoconstriction. They lost elasticity within those arteries and veins. And now we're giving them horse urine, which is making that significantly worse. And so yes, a lot of women did die of heart attack or stroke. Another thing with the study is Premarin and Prempro is not a biestrogen. And so if you remember, I mentioned there are 3 types of estrogen in our body. You have to use E2 and E3 to balance out E1, which decreases the risk of getting breast cancer. And so when they did the study, they didn't know that. And essentially what the researchers had said was, it's okay to use hormones in women. And if you're old enough to know this from this study, just even a decade ago, it was okay to use hormones in women, but we don't want to use it longer than 5 years. Because when you use it longer than 5 years, then you're definitely going to give someone a heart attack or stroke or breast cancer. What they actually learned in further research studies was using by estrogen, or the two different forms of estrogen, we are decreasing a woman's risk of getting breast cancer. And so the literature was right, it did increase that risk, but it's because they weren't using the two types of estrogen. Now, when you talk about using synthetic or bioidentical hormones have the opposite effect of horse urine. It actually vasodilates. And by vasodilating, it's decreasing your risk of having a heart attack or stroke because now your arteries and veins aren't constricted. And then we also learned that we needed to use progesterone. Progesterone actually protects your uterus, and so it decreases your risk of getting cervical cancer. And that's because you don't want too much of that estrone or E1, which contributes to breast cancer or cervical cancer. And so this was an unexpected or incidental finding, but because of the initial study, which states you can get breast cancer from using hormones, the government's not going to retract that statement. And so you honestly need to understand the difference between synthetic hormones and bioidentical hormones and how that risk is increased by using either of the two hormones. This is looking at menopause and Alzheimer's disease. And it is so essential to keep estrogen in the brain, not just for brain function, but this is why a woman's risk of dementia and Alzheimer's is significantly higher. You can see on the left in the premenopausal brain, you have more activity here. And then on the right in a postmenopausal brain, decreased activity. And so that forgetfulness that you feel as your hormones start changing, that's because women need hormones in their brain, not just for sleep, but more importantly for brain function and to prevent Alzheimer's or dementia in women. Did I skip? Okay, and then this study, and I'll send the slides out so you can look at the studies yourself. There's lots out there, but these are the main ones. It talks about reducing the risk of endometrial cancer. So during the Women's Health Initiative study, they were only using one form of estrogen in women. They were not using progesterone. And so current research today shows that you have to use progesterone when you're using estrogen. You never want to use them separately. And so all of my patients are on progesterone at night, but it's also important because progesterone helps with sleep and you need it in your brain. But equally important for the uterine, so you don't get endometrial or cervical cancer. I wanted to include what the American College of Obstetrics and Gynecology had said. So a decade ago, they said, don't use hormones for more than 5 years. This is their current statement. Because some women that are 65 and older may continue to need systemic hormone therapy for the management of vasomotor symptoms, ACOG recommends against routine discontinuation of systemic estrogen at the age of 65. And so pharmaceutical companies can afford to do the research on using hormones, which is your synthetic or horse urine, but you're not going to see as many studies on bioidentical. And so when they had said don't use it for more than 5 years, we realized that women need hormones. And so these statements came out, I believe, in 2018 or 2019 that state, okay, let's use hormones in women, but each woman is going to be unique. So if you want to keep them on hormones, just know that after 5 years on synthetic, these risks go up. But they haven't caught up with the literature as to how bioidentical hormones help. But the literature is out there, and you should stay on hormones post 65 years old. The North American Menopause Society also states that for women younger than 60 or within 10 years of menopause onset, there's no contraindication. So there's no reason to not use hormones in these women. The benefit risk ratio is most favorable for treatment of bothersome vasomotor symptoms. And so what that is the night sweats, the hot flashes, the brain fog, for vaginal dryness, for all of these symptoms that your patients are having, it is more favorable to treat them with hormones than not. But more importantly, it decreases your risk of osteoporosis, which as you age, that risk significantly goes up. So what's the next step in determining if you need hormone replacement? You're gonna want to schedule an office visit. Each person is unique, and the longer that your body has gone without estrogen, your circumstances are going to be very unique. All hormones are recycled in the gut. So when I'm looking at a patient from a functional medicine perspective, what their gut is doing to me, first and foremost, is the most important. And then I want to know if their liver is able to produce or metabolize the hormones. And then I want to know what their adrenal glands are doing, because if you don't have the key to let the hormones in your body, then it's just going to cause more weight gain, and you're actually going to be more tired because of the chronic fatigue that the hormones are going to cause that are being recycled and turned into more progesterone. The thyroid is also a hormone that's going to be affected by the adrenals and your sex hormones. And I'm looking at nutrient and vitamin deficiencies. So are you able to methylate your B vitamins? Do you have a magnesium deficiency? I see it in a lot of patients. And are you getting enough zinc so that if I give you hormones, it's actually going to get in the cell to do what we want it to do? And then when the body is under stress, or if there's viruses or bacterial infections or toxins, then that may be the reason why your hormones aren't doing well. And as a functional medicine provider, those are all things that I look at. Labs. I look at a multitude of labs. In the clinic, you can use insurance for labs, or you can pay cash, and I get a really good price on hormones and lab work. But if you look at this picture to the left, I like to measure inflammatory markers in patients that are postmenopausal, because I want to know if their risk of having a blood clot is imminent or not a risk at all. Or I might ask about a coronary artery scan. Has your doctor looked to see if you have plaque buildup? When I'm looking at hormone labs, those might be some additional labs that patients are asked to do. Hormone replacement recommendations. I don't use synthetic hormones at all. They actually waste energy. So it's just hormones circulating in your body, taking up energy that you already don't have or don't want to lose. It causes incomplete messages to cells, which just creates more free radicals and different chemical reactions that lead to more problems in your body. It causes the vasoconstriction, which increases your risk of a heart attack or stroke. And I don't use pellets. I get that question a lot. The reason why I don't like pellets is because it causes inflammation in the body, and all chronic diseases come from inflammation. But more importantly, when you place a pellet of estrogen or testosterone or progesterone in someone's body, you can't remove it. And so if you're having side effects that are undesirable from your hormones, you actually have to wait 3 to 6 months for the hormone to run out. I only use bioidentical hormones. I use estrogen in a cream form. I use progesterone in a capsule form because that's what supports the brain the most, but it also helps your estrogen go down the pathways that we want it to go down. And then I use E2 and E3, or a bi-estrogen cream, in my patients so that they don't get too much of that E1 that can lead to breast cancer. Use DHEA in a cream or capsule form. And that's in some, not all patients, and then testosterone in a cream form for patients who need testosterone. When using hormone replacement, you never want your testosterone to be higher than your estrogen. It's when estrogen is higher that gives you that hourly body glass figure. When testosterone is higher, then it's going to give you more of a manly figure. It's going to give you facial hair and all of those other androgen symptoms that we don't want to see in patients. We want to feel good as we age as women, and it's completely a balance. And so with that in mind, I monitor hormones every 3 months. I'm very conservative in how I use them. There are standard doses for hormones, and I actually start my patients on doses much lower than standard doses because I want to see how they feel with the initiation of hormones. We follow up every 3 months, and then I fill hormones for 90 days. I get some patients who have been on hormones for a year and no one has ever looked at their lab work, which just surprises me every time I hear it. And so if you're getting hormone replacement somewhere else, these are things you want to keep in mind when you're considering hormones. You can use insurance for lab work. And then the Dutch test, I like to do on every patient around 3 or 6 months. So I start out very low. And so for some patients, it may not be until 6 months because we don't get them at a therapeutic level until that time. When my patients are at a therapeutic level, and yes, that depends on how they feel, it depends on lab work, then I want to know what pathway is your hormones going down so that I can push you down a healthy pathway. We have a 12-month membership program, which is what I recommend for my hormone patients. And what that includes is health coaching or one-to-one coaching. And that's because stress significantly affects hormones, just like diet. And so it's important for me that my patients are working one-to-one with health coaches so that they're on the correct path with hormone replacement. Otherwise, it's just dropping a pill or something in your body and hoping it will work. But if we're not doing all of the other things that significantly affect hormones, they're not likely to work as well as we want them to. And then I teach group classes like this monthly, where I encourage patients to come and ask questions and learn more information, because I want every patient to feel comfortable with their plan of care and the direction that we're going with hormones or whatever it is they're a patient for in the clinic. With the medical membership, you also have access to messaging. And so patients message me all the time. The goal is for each patient to move forward. And so, if you're having an undesirable symptom or side effect, then I want to know about it and not wait 2 months till our next appointment to do something about it. And then you also get discounts on supplements and services in the clinic. And so that is the presentation on hormone replacement. If you have any questions, I'd be happy